Hi again. It's Sunday morning for us, and we're doing another podcast on return to healing. And we're going to continue our conversation about primary care. And Alan and I found a great article that it says a lot about primary care. So, Alan, you take it from there.
So this was an article published in June in the Journal of Graduate Medical Education, which is like the journal for teachers of postgraduate education and residency training. That's what people need to do after medical school to go into the field they choose. And unfortunately, the teaching piece is called A Eulogy for the Primary Care Physician, and it's going to take me about 2.5 minutes to read, but I think it will bring up a lot of talking points to us. So I think it's worth it for you guys to hang in there for 2.5 minutes of our time. So it says, we are gathered here today to bid farewell to a pillar of American healthcare, the primary care physician. The role of the PCP was born from a simple, noble idea that every patient deserves a trusted doctor who knows their health inside and out, who guides them through the complexities of the medical system, and who fosters relationships not with charts, but with people. This role grew from the heart of medicine itself, offering care that transcended physical ailments to address the whole person. The PCP was once the embodiment of trust, consistency, and comprehensive care, rooted deeply in the communities they served. Today, we mourn the passing of this figure, a victim of systemic failures that spread like an untreated infection, eventually ravaging the very core of the profession. At its height, the role of the PCP was prestigious. Medical students aspired to it, drawn to the close bonds they could form with patients and the potential to influence health at a fundamental level. The PCP wasn't merely an individual with a stethoscope. They were a figure embodied in the fabric of the community. They were the honor in long hours. They packed schedules and house calls. For many, the PCP represented not just a career, but a calling. And I think me and Andy think medicine is a calling. The symptoms emerged quietly, at first in rural and underserved communities. The shortage of physicians was a whisper of what was to come, unaddressed, the ailment. It was fed by a broken insurance system that prized procedures over cognitive work and the treatment over prevention. The work of PCPs was measured by metrics that didn't reflect their worth. They were marginalized in a system that revered specialists and high-tech services that only hospitals could provide. They struggled to survive economically and emotionally. To cope, the PCTs did what they could. They saw more patients in less time, hoping to keep their heads above water. But working harder just delayed the inevitable and made the underlying ailment worse. The more they pushed, the more they wore themselves down, and the weaker they became. And then came the most sinister part of the disease, burnout. Exhaustion, once a manageable ache, became a crushing weight. The constant pressure of seeing too many patients, the administrative burdens, the endless paperwork, it all conspired to sap the PCP's lifeblood. Burnout was no longer an exception, but the rule. PCPs found themselves feeling detached emotionally and exhausted with little to give. They were doctors, but the healer's light within them started to dim. And the cures, the ones that could have saved them, they were there: improved reimbursements, loan forgiveness, administrative relief, but they were ignored as the patient deteriorated. An opportunistic infection signaled a terminal stage. Private equity, like a cunning virus, sensed weakness and struck. Driven by private equity firms infiltrated the healthcare system, rapidly consuming practices, turning PCPs into mere cogs in the machine. They saw not doctors, but businesses, not a calling, but a profit center. The holistic patient care that defined the PCP was reduced to a spreadsheet calculation. As the private equity's grip tightened, medical students and residents turned away from primary care. Plagued by increases in medical school tuition and rising interest rates, they saw the writing on the wall. The prestige of primary care was gone. It promised nothing but pain, burnout, financial strain, and disrespect. Slowly but surely, the vital signs of primary care grew fainter. The time came when only one resident in graduate medical education programs chose a career in primary care, and just like that, it slipped into history, leaving an empty space at the heart of the profession and the heart of healthcare system. The story of the PCP is a story of opportunities missed, of remedies ignored, of a system that allowed a treatable contagion to spread unchecked. Today, we mourn not just a profession, but the spirit of care that it embodied. Let us remember the PCP not for the way they ended, but for the life they lived, one dedicated to healing in the truest sense of the word. The PCP is survived by the independent physician assistant, the nurse practitioner, and generative artificial intelligence. I think, Andy, like this article editorial, like summarizes the history of primary care and what happened to it.
Yeah, I mean, it absolutely does. And when I listen to you read it, I feel because I worked in a very small community when I started. And I used to go to the store and some of my patients or their families would see me and they say, "Look, that's my doctor." And I always felt like people say, "What kind of doctor do you want to be?" I say, "I want to be a person's doctor. That's the kind of person I want to be. I want to be the person who knows them really well and can help them through all sorts of crises and really be able to explain things to them and they trust me and I trust them." And that part of medicine is not only undervalued, but it is disappearing. And too many primary care doctors now, by necessity, are simply referral machines. People come to them and they just refer out, and they don't have time to sit with them and get to know them. And like you say, the burnout and the turnover, um, end up just going there to get a cold taken care of now instead of going to this trusting person who you really want to sit down and talk to. Alan and I, you and I still do that. I don't know how we've sliced out a piece of this crazy specialized world to do it, but we do, and that's what gives me my joy every day of working. So I do think, as much as the eulogy occurred, that there is a way to fix this. It just would mean, like you said, there has to be reimbursement reform, without a doubt. We can't be paying radiologists more to read an X-ray than doctors like us to come and take care of whole patients and complex problems. You just can't do that. And also, we have to realize that all the burden of filling out paperwork and doing quality indicators is getting in the way of us and patients. It's not helping. Quality indicators detract from quality. And so we have to remove all that. There are people who scream and yell about this, who write books about this. And it's really, I mean, what do you think? It's surprising that no one gets it, who's making decisions. I guess money talks. I mean, we actually lose money for the system in the sense that if you see primary care doctors, the system pays a lot less money for a lot better health. And so a lot of people don't get paid. And maybe that's what it comes down to.
Well, Andy, I agree with you 100%. A couple of comments to what you said. Well, number one, we don't really need radiologists anymore because, AI, as the article ended, could read an X-ray better than a human at this point. So, any of our young docs on here who may want to go to a radiologist, unless you're looking to be an interventional proceduralist radiologist, I think you're making a mistake. But I think me and Andy, I think you agree that medicine was a calling for us. It's in our hearts, it's in our souls. Nothing makes me happier right now than when a patient comes into my office with one of our books right now and asks me to sign it and says, "This is my doctor." My doctor wrote this book and asked me to write something to them. Like nothing feels better. Like, there's a relationship there with some of my patients now for 38 years, continuity relationships. And no one could tell me that the care I could give knowing someone for 38 years is not better than some hospitalist that meets someone in the ER, 10 minutes ago, and their goal is to get them, in and out of the hospital in 2 minutes, or the cardiologist who sees someone in one visit and says, you need a cardiac cath and a stent, even though you're having no chest pain symptoms. So we could go on and on. I know next week we're going to try and focus positively and talk about what's good. And I have a proposal for the week after, Andy, or my wife will kill me because she said we
Okay.
best specialists. So we need to talk about the importance of specialists, and not only the importance of specialists, the importance of good specialists, because having good specialists doesn't actually add to the care. So when you get a cardiologist that doesn't, cath everyone, it's a good thing. But I don't think, and I don't want to bash the new generation. I know we're all hearing this. Our younger doctors, the family doctors in my residency program, it is not a calling to them. It is becoming shift work. They want to do activism and they want to do community service and they want to care for patients, but most of them honestly want to do it between 9 and 5 and 3 or 4 days a week and no nights and weekends. It's a change in our world. We know that, want to work at home world, but and even some of them ask that, can I have, one day to work at home to do televisits and catch up with my charts?
Yeah, it is becoming, we are becoming a lazier world. That's part of a progressive society, as a history person, you can see that in almost every society. But even in a lazy world, we could have people still getting to know their patients, and still having an opportunity. And look, people who do what we call concierge practices, and obviously this is a model we'll talk about, I guess next week. But they do see fewer patients and they love what they do. And Alan and I wrote an
Mhm.
article about, expanding that model to everyone, which would be one solution. And when our book is a lot about how industrialized profit medicine started in 1911, and it was started by a guy named Flexner who actually maybe wasn't a bad guy, but was a puppet for the people who really wanted to create a corporate system. Um, and Osler was the guy who was the heart of medicine, who believed that this was the wrong direction. The one thing the two of them agreed on is the only way the system is going to work is with a strong primary care base. And they both believed that primary care was the key to medicine. And somehow we lost that. And I think, people who go to see this specialist and that specialist, it's reminded of my grandma when she was 92 years old, and she really had nothing wrong with her and saw 8 different specialists. Basically, because she had to see a bladder guy and a cart guy. She had nothing wrong with any of those things. I said, Grandma, why don't you just see a regular doctor for all this? She said, why would I see one regular doctor when I could see experts in every little part of my body? And that view is so erroneous, to slice up a body into pieces and to treat it that way is so antithetical to a person's health, but even more so when you're just talking to the heart guy doesn't know you. They know some measurements about your heart. They don't even know your heart, to be honest with you. They know measurements about your heart. Whereas the primary care could put it all together. And God knows, Alan, that's what we need in this world. But if we had that, a lot of people would not be making the money they're making off our healthcare system. The trillions of dollars are spent on care that is not necessary and dangerous.
No, no. Andy, the answer, the problem is the medical industrial complex that we call it. The hospital insurance industry, big pharma, the device makers, insurance companies, and really, unfortunately, the medical societies of those physicians that are making tons of money. And it is about, unfortunately, the money. It's always about the money, I think, in this country, not about health. And most of the world does have a primary care based system where it is about the health and not the money. And our system is based on profits over the health of patients, unfortunately. How many, big procedures could we do? How many drugs could we give them? Because the more the better, because the more we do, the more we prescribe, the more we spend, the more money the medical industrial complex makes. And so it is. It's about profits over patient care. It's just, unfortunate, but that is what it is.
And one last thing I'll say before we end is that what makes me upset about it is, my patients who have known me for a very long time buy into the primary care model. Because I'm their primary care doctor, and they know how much I care. When they have a question for me, I read. And I don't just read headlines, listen to CNN, or look at what the American College of Physicians says. I read deep, and I look at nuance, which most doctors don't have time to do. But what upsets me more than anything is why the patients aren't rebelling against this, because I think they've been sold. It's almost like a religion. They've been sold this bill of goods that the more specialists they see, the healthier they are. But in the context of that, we are living shorter. we're sicker, we have more chronic disease. And why don't they see that? I mean, that's what upsets me is really if this rebellion is going to occur to create a primary care base, it has to come from below. But yet somehow the patients in this country, the people in this country have been largely duped into a specialty-based system. I see it in my own family, that they buy into that, and that's what has to change. And I thought I was hoping COVID would change it because we see the bankruptcy of a system that is, we had the worst outcomes in the world, based on our system, and yet people said, "Hey, we did okay." And that discordance between reality and how people think we're doing. Everyone says, "Well, how bad could it be? We're living longer than ever." I said, "But we're not, and we're living shorter than every other country in the world." I said, "Who told you we're living longer than ever? We're living shorter than we did 20 years ago." And we're spending 3 trillion more dollars in healthcare to live shorter. But they don't see it that way. So
So,
that's been the hardest part for me is just trying to convince people.
so a quick one. I'm preparing for a grand rounds on the healthcare system, not our book, unfortunately. And I dove into an article from something called the Commonwealth Fund, which studies healthcare a lot. It's called Mirror Mirror 24. And essentially, it was a series of charts that say what Andy just said, documented in real numbers. We pay about twice as much as the next leading country on healthcare for the most inefficient, inexpensive system. We have higher infant mortality rates than most of the world, higher maternal mortality rates than most of the world. We spend more time in the hospital than in most of the world, especially at end of life. We utilize like hospice care type care less than most of the world where they don't necessarily call it that. And we're living shorter and shorter every year. And we're becoming fatter and fatter and more chronic complex illness. And we're not investing in a system based on wellness and health.
Yeah,
But
and
next
that
week, we will talk about how to fix the system because it's actually really easy. And in I think mine and Andy's opinion, it's not only better, but it's going to save our country a lot of money.
more money than any other thing we could do. We could save enough money to create Medicare for all, and with everyone's screaming about. Okay, Alan, I'll see you next week.
All right. Have a great week, everyone.